to introduce today Professor Marc Gewillig, who is going to talk today about the Fontan circulation and what have we learned after 50 years. Professor Gewillig is probably the world foremost expert on the Fontan circulation, and I cannot think of anybody better than him to teach us about the Fontan. So, Professor Gewillig, thank you for joining us, and the floor is yours.
Okay. First of all, thank you very much for the invitation. It's a pleasure of presenting here at the Toronto International Round. I have no disclosures concerning this presentation. So as you all know, the first operation, Fontan operation, was performed in '68 and reported in '71. So that's about exactly 50 years ago that we can look back on that experience. Here's a drawing, a cartoon of the very first Fontan operation, and as you may notice, Mr. Fontaine in Bordeaux did quite a few other things than currently we are doing, and indeed it has evolved a lot. Now, I personalized a little bit the title of this presentation. Indeed, there is 50 years to span. Myself, I got involved in Fontan operations in the late '80s when I started to write my thesis. And I will speak over here, I will tell over here what I was taught in those days. And after the presentation, I will come and see what I'm teaching nowadays. Well, back in the '80s, I was taught that a Fontan operation was difficult cardiac surgery and that you needed the best cardiac surgeon around to perform such surgery. Indeed, after the operation, we saw a ventricle that was big. Typically, we would call it dilated. It was dysfunctional because the lungs were put after the systemic resistance. We considered the afterload to be increased, and I mean, we've been mixing up a little bit afterload and systemic vascular resistance. For us cardiologists, namely because of the cardiac surgery and the obvious problems with the ventricle, we were speaking about heart failure. And as cardiologists, once you hear the word heart failure, it is obvious that we think about our heart failure strategies. And every cardiologist will be able to tell you that our heart failure strategies consist of dealing with contractility, heart rate, afterload, and preload. As cardiologists, we are very much acquainted with how the cardiac output is being determined. This is a formula we all know very well. And so we speak about the ventricle trying to maintain its stroke volume and trying to cope with the situation. And we have trying to specialize ourselves in treating the failure and to improve the circuit at almost any possible level. I must say that keeping the heart then as a center of the circulation was what is expected from us as cardiologists. However, I think most of us have experienced a lot of frustration. For instance, the heart failure strategies, most of us have experienced that we can make the Fontan ventricle contract harder, but it will not contract more. Heart rate has hardly any influence. Dealing with the afterload hasn't been helpful at all. And also over here, we did invent the word chronotropic incompetence in these patients. However, making the heart beat faster didn't solve the problem. So everybody was feeling that there is a problem. Now, before going into the details of Fontan circulation, I think it is very important that we are sure that we understand the advantages of a biventricular circulation. And here now in a typical biventricular circulation, obviously you have the two ventricles, left or right. Blood is being sucked from the left atrium and pumped into the aorta. And this energy is then lost over the systemic vascular distance. Blood is collected in the right ventricle, the right atrium, right ventricle, pumped into the pulmonary artery, and so on. So that means that a normal circulation, biventricular circulation at rest, has an output of about 100% of normal. normal person can increase it to 5-fold with maximal exercise. And typically, RA pressure is low, there's pulsatility, and we are fully saturated. Now, this is the cartoon I like very much to depict how a Fontaine circulation looks like. So we now have just one ventricle. The blood is being pumped from the left atrium into the aorta. And over here, the systemic resistance, instead of losing all this energy, know that energy is being collected, preserved, to push down the blood through the pulmonary arteries. What are the characteristics of this circulation? Well, at rest, it will not be as efficient. It will be slightly lower than normal. And also with maximal exercise, even our best patients cannot compete with normals. Typically, central venous pressure will be high, pulsatility will be gone in the modern circuits, and depending on whether there is a fenestration, yes or no, there will be full or not full saturation. Now, another way to look at this is that we have put the pulmonary vasculature in front, ahead of the ventricle, like a dam. And if you consider it this way, then you can immediately explain with this new portal system that was created, the two prominent features of any dam, namely the congestion and increased output. And that is what all of you know. If you have a dam over here, you always will get upstream the congestion and downstream over here the controlled flow. Now it is exactly these two features, the upstream congestion and the downstream decreased flow, that will determine all the problems in a Fontaine circulation. Again, let's first try to understand what it means for the overall circulation. Here a cartoon what a biventricular circulation with a normal ejection fraction can do from rest, doing nothing, to maximal exercise. There, a normal ventricle or a normal cardiovascular heart will be able to bring the output from 100% and increase it to 5-fold when, for instance, running a marathon. What with our best Fontaine? Well, our best Fontaine at rest will have a slight decrease of his output at rest. And with exercise, obviously, he can increase his output, but not as much as a normal person. That is our best Fontaine. What about the worst Fontaine? Well, at rest, you will have experienced that they will have a significantly decreased output at rest. And with exercise, they can increase their output slightly, but I mean, it is very, very limited. So this cartoon means that all our Fontaine patients are in between these two lines. And it is our job as either pediatric or adult cardiologist to keep our patient away from this point over here. I spoke about dam, and in certain patients, we can have what you can call excessive damming. So the upfront, too little flow goes through it. And that will result in an excessive decrease of output, and which will result in premature death, exercise intolerance, or a significant development of collateral flow, or excessive congestion with edema, effusions, liver dysfunction resulting then in fibrosis, cirrhosis, and cancer, or lymphatic leaks, and I'll come back to that later on. If we don't like the result of what the surgeon did, I mean, there is a possibility of what you can call progressive undoing of the Fontaine circulation. And allow me to walk you through this cartoon. What happens with ventricular output as we create a Fontaine? Well, typically those patients will be shunted, and quite good shunted, to their lungs. When we take them to a Fontaine, to the glen as a single source for pulmonary circulation, there will be a significant decrease from the output for the ventricle, which will be further decreased by the Fontaine state itself. That for best Fontaines. The worst will be something like this, with a significant, very significant decrease of output. What will happen to the saturation? Well, we all know the big advantage of a Fontaine is that at rest, both the bad and the good Fontaine will be nicely saturated. However, at what price? In the good Fontaine, a mild increase of his central venous pressure. In the bad Fontaine, a significant increase of his central pressure. So for the good Fontaine, This is a reasonable compromise. However, for the bad Fontaine, this may be miserable life with low output and heavy congestion. As I said, we can gradually undo this Fontaine, and that's what we call making a fenestration. And theoretically, you could take it from 0 to 100% fenestration, which means complete takedown. What does that mean for output? Well, the output, obviously, for both the good Fontaine and the bad Fontaine will significantly increase, and it should, in theory, normalize. The other good thing is, if you make a fenestration, the central venous pressure or the congestion will decrease to near normal levels. So that's the good news. What's the bad news? Well, obviously, as the blood is no longer going through the lungs, the oxygenation will significantly decrease, and the patients will become cyanotic, very heavily cyanotic, unviably cyanotic. This means that the good Fontaine may not need a fenestration at all, and in the bad Fontaine, it will be very hard to find, especially for a secondary fenestration, a nice balance between output, congestion, and saturation. And sometimes there is no good compromise possible. Now, before I go on, let's go for first a few very basic questions and answers. First basic question: can one create a Fontaine circuit without touching the ventricle? Well, the answer is quite obvious nowadays. I think we have shown that the essence of a current Fontaine circulation is non-cardiac. The operation is limited to connecting the caval veins either directly or through a tube to the pulmonary arteries. Fontaine connection nowadays has become non-cardiac, extracardiac, actually vascular surgery. There is no necessity for an extracorporeal circulation, and the surgeon can do it without even touching the ventricle. Now, the implication of this statement is enormous. You may not estimate this, because it means that all the changes that you see at ventricular level are secondary changes imposed by the new boundary conditions. And again, being a secondary change has enormous influences. I'll come back to that in a second. Now, am I very sure that indeed the surgeon never touches the ventricle? As I said, it's extra and non-cardiac surgery. The ventricle is untouched. There is a few exceptions, and actually there's 5 exceptions. Sometimes the surgeon will do a short arrest, for instance, for doing a septectomy at the time of a Fontaine, but we try to avoid that. I mean, the septum should have been opened way before the Fontaine. So this is exceptional nowadays. He may use some cardioplegia, but usually they create a Fontaine on a beating heart, but they may need cardioplegia to do these things over here. Again, that is exceptional nowadays. A ventriculotomy, especially with the Demus-K stencil, is very, very exceptional. Though these 3 things nowadays are very exceptional to perform at the time of the Fontaine operation. In the 80s, when I started first to see the Fontaine operations, it was not uncommon to unload the ventricle to its critical level. The next slide will deal with that. But what is not uncommon, and what we do in all our patients, is we change the boundary conditions, and that in the long term will result in a decreased compliance, and probably the biggest cause for that is the chronic deprivation. Again, I'll come back to this later. Let me first talk about working closer at your closing volume. You know all the Frank Starling equation, where a decreasing preload will result in a decreasing stroke volume work for the ventricle. Now, this line obviously doesn't go through 0. A ventricle, any muscle, needs a minimal preload in order to develop force. And so if you go under this, your ventricle may fall apart. Now, that was a typical problem in the 80s. Why? Because in those days, we went from a double shunt, usually big shunts, from a double shunt to a full Fontaine in a single step. So these ventricles were critically unloaded, not only by taking away both shunts, but also by imposing the Fontaine conditions on that ventricle. And I must say that frequently we looked at the patient with scary eyes, as they entered the intensive care after such an operation, just to see whether the ventricle would cope with that extreme degree of unloading. These conditions nowadays are exceptional. What is not exceptional, and actually what we observe in every Fontaine patient in the long run, is that early after a Fontaine operation, we see some nice diastolic function, nice pressures, and late after Fontaine, almost invariably, we will see increasing filling pressures, decreasing compliance of the ventricle. Next basic question: how do you improve flow in a circuit when an obstruction occurs? We as cardiologists should be very much acquainted with the answer to this question, because that's a problem we're dealing with on a daily basis. Now, theoretically, if you have your tubing over here and the resistance can be imposed over there, what are theoretically your options? Well, either you can push harder upstream over here, you can deal with the obstruction, or you can pull harder downstream. Now, if you ask me what is the most efficient, or what are the best options, well, dealing with the obstruction obviously will be the most efficient. If the obstruction is gone, there is no more problem. The second option is push harder, and the least efficient almost invariably is always pull harder downstream. And you already hear me coming, because the obstruction is actually the dam, and if we from ventricular side want to improve the situation, you know that the ventricle is not very good in pulling in blood. Next basic concept: what do you do with multiple bottlenecks in series? I mean, here you see a cartoon with several bottlenecks, and with a blink of an eye, all of you already will have determined by now where is the critical bottleneck. We will all agree that changing things over here at this bottleneck, I mean, opening up this bottleneck over here, will not change a little thing, anything in the whole circuit. It's only when you work over here that you will change the flow through the whole system. So there is a theory, and it's true throughout the universe. If you have multiple bottlenecks, there is always only one critical bottleneck, and that's the only thing to work on. If you work on the critical bottleneck, you will see a change. If you work at the other bottlenecks, you will see no or almost minimal change, and most of us should consider that as an irrelevant intervention, because it will not change. You will say, whoa, what is all this? Is this a new theory? Things like that. No, but usually the problem with critical bottlenecks is so obvious that this reasoning, you do it in a blink of an eye. For instance, in the case of cardiomyopathy, in the biventricular circulation, I mean, the word says it itself, the critical bottleneck is the ventricle. So how can you deal best with this problem? Well, either you make the ventricle squeeze harder, that's dealing with the problem itself, or you push more upstream. That means you load the left atrium pressure will increase and the ventricle will be more performant, or you decrease the afterloads. So it's always the same story. Same for instance, pulmonary hypertension. The problem is over here. So either you deal with the pulmonary vascular resistance, or you push harder, or you pull harder over here, which is very difficult. The same thing with mitral stenosis. The problem is then over here. So either you deal with the mitral stenosis, the valve itself, or you push harder at left atrial level, or you push harder, you pull harder in the ventricle, which all of us know is not that easy. Now, what about the Fontaine circuit? If you look at the cartoon again, I just mentioned before that making a fenestration does two things. It will decrease the congestion over here, and it will increase the flow over here. So that means that this bypass, if that bypass is so efficient, it means that your critical bottleneck is in between the 2 points of your bypass. And so what does your critical bottleneck consist of? Well, it is either the Fontaine connection itself, here the surgical connection, or the big pulmonary arteries, which can be hypoplastic, stenotic, kinked, compressed, whatever. The pulmonary vascular resistance over here, the pulmonary veins, which can be squeezed, compressed, externally compressed, and then last but not least, left atrial pressure. Of course, bypasses can alleviate the whole system. And that brings us to these cartoons over here to illustrate what is the relationship between output and pulmonary vascular resistance. If we do that now in a normal heart, well, in a normal heart, if you increase slightly the pulmonary vascular resistance, output will not change. Why? Well, these patients have a right ventricle, and as pulmonary vascular resistance goes up a little bit, the right ventricle will squeeze harder and you will not observe anything. And it's only way out of this slide at a resistance of 20 or 30 that the right ventricle will no longer be able to cope with the increasing pulmonary vascular resistance. The picture is completely different in a Fontaine circulation. Here, our best Fontaine patient with here a normal status. And we all know that, for instance, if we would intubate this patient and give him PEEP, just giving the PEEP, it will increase the pulmonary vascular resistance, but it will decrease the output throughout the whole system. Inversely, as we decrease pulmonary vascular resistance, in the patient with a very good or a medium ventricle, I mean, it will decrease. Sorry, it will decrease decreasing the pulmonary vascular resistance will increase the output. If your ventricle is really burned out, I mean, there is a level that you will not be able to pass. Similarly, what is the relationship between circulatory output and ventricular contractility? Now, the doctors that are dealing with heart failure, congestive heart failure, will be able to confirm that as you decrease contractility of a left ventricle in the biventricular heart, it's only when you reach a certain level that you will see a decrease in your cardiac output. The same thing does happen with patients, with our best patient with low pulmonary vascular resistance. So at rest, his output will be slightly decreased, and decreasing ventricular function will not significantly alter the output unless you reach a certain state at the very, very low levels. Now, this cartoon also immediately illustrates if you have a patient over here with a mediocre output and you would love to improve his condition, well, increasing his contractility will not solve your problem. It just will move along the line. In contrast, decreasing pulmonary vascular resistance gives you the best option for this patient to increase his cardiac output. What happens with the Fontaine in time? So if this would be the Fontaine circuit at the time of creation, I mean, by experience, by observing, we all know that in time, this will happen. Central venous pressure will increase, but most importantly, the filling pressures in the ventricle will increase significantly. This, together with a mild increase in pulmonary vascular resistance, explains to you this plus this, that more congestion, less output. Frank Starling tells you, well, contractility will decrease, and less output always in any circuit will be associated with an increase in systemic vascular resistance. This brings us to this cartoon. What happens? How does pulmonary vascular resistance evolves during life? Well, in normals, it appears to remain low and stable for a very, very long time. And as you get in your 70s and 80s, there may be a mild increase, usually not a critical problem to become dominant for the clinical picture. What about our best Fontaine patients? Well, my best Fontaine patient is now a little over 60, and now she's getting worse, but she has been keeping her pulmonary vasculature very, very low for a long time, and now she's getting into trouble, not because of the pulmonary vasculature, but because of the filling pressures of her ventricle. But what with patients who have a mildly or a moderately increased pulmonary vascular resistance? Well, here we see that typically after the second decade after puberty, in their 20s, early 30s, we see a significant increase in pulmonary vascular resistance, which may deteriorate these patients. And what about our worst? Well, these are patients where we probably took too much risk. These patients probably never should have been offered a Fontan operation in the first place, because in those patients we see that very early after Fontan, we see already an increase in pulmonary vascular resistance and the whole circuit falls to pieces. What all of you are busy with is how can you influence this with maneuvers or medication, and I'll come back to that in a second. I already have stressed now a few times the importance of pulmonary artery flow, because the blood will have to go through the lungs without a pump. So you want those lungs to be as nice, as good and as nice as possible. And that means we have to be aware before the Fontan operation, a lot of nasty things can happen to those pulmonary arteries. They can become stenosed, distort, or kinked, either from the surgeon or the ductus which will close. We can lose or exclude large vessels. They can become, remain too small, hypoplastic, or they can be flooded and get some pulmonary vascular disease. They can be compressed externally. So that are all the nasty things before a Fontan operation. We have to realize also that the Fontan status itself is not the nicest thing to happen for your pulmonary vasculature. For instance, there is no pulsatility. It's very steady and chronically low flow. Bad for the pulmonary arteries. It is important that they regularly get flushed. There is absence of episodes of high flow, high pressure. What all of you do, if you just climb one flight of stairs, automatically you will flush your pulmonary vasculature, you will recruit your apical segments. Fontans don't do that easily. I mean, it's much more work for them. They also are subjected to inhomogeneous distribution of whatever hepatic factor we still don't know. Collateral flow, circulating vasoconstrictors, and less vasodilators. All these things are bad for your pulmonary vasculature. This already then predicts that when we're going to talk in a few seconds about vasodilators, well, that the effect of those pulmonary vasodilators will be limited, because the vasodilators only will touch on this and on this. All the other issues are untouched by the vasodilators. So don't expect a fantastic response or a solution to all your problems with pulmonary vasodilators. Another thing that some of you sometimes tend to forget is that every ventricle in a Fontan circulation has a history. If you take here the pressure volume loop for a normal left ventricle, well, during fetal life, the left ventricle in a tricuspid atresia, for instance, has to do all the work. So by definition, the PV loop of a left ventricle in tricuspid atresia will look like this, where all the work of the normal right ventricle and the left ventricle will be done here by the single left ventricle. This is a new relationship of the ventricle with its body surface area. But after birth, this changes. Typically, we will impose on that ventricle a high pulmonary blood flow, which will make the PV loop like this. And now we lose almost completely the relationship between the ventricular size and the body surface area, because the size of the ventricle will be much more dominated by the pulmonary blood flow than by the body surface area itself. When we go then from this to the Fontan state, I mean, we take away the enormous preload. We end up with a ventricle which is still big and which will have a slightly decreased stroke volume. And as time goes on, as we already discussed, the stroke volume will come down and the filling pressures will go up something like this. So this is the ventricle, the typical ventricle that you as an adult cardiologist will see in your adult patients with a Fontan circuit. And now comes the big thing. This ventricle has evolved from previously overloaded and stretched during fetal life and the initial shunt before the Glen, and it has evolved to a Fontan state. And the typical thing over there is it's chronically now volume depleted. The ventricle is big, indeed. It is bigger than normal, but I mean, should you call it dilated when you know that it is coming from this side over here? I mean, it is definitely overgrown because of the big shunt, but instead of calling it dilated, probably a word like collapsed is more appropriate. Another thing that we cardiologists have to consider is, or be aware of, is the difference between a pressure pump, which gives you positive pressure, and a suction pump, which can suck the fluid into the pump itself. I mean, every fireman knows that that is a different pump. When they go and blow out a fire, they will use their pressure pump. However, if they have to go and get water from a lake or a pond, they will use their suction pump. Now, if you're lucky, you can have a thing like that. It's a pressure suction pump. But only few animals have this. For instance, a shark has this. A shark has a heart that can give very good pressures, an ejection fraction of almost 90–95%. And with such a high ejection fraction, it also creates a suction. Now, we speak about a heart as if it were a pressure suction pump. Reality, however, is that the Fontaine ventricle looks much more like this. I mean, it can generate pressure, but calling this suction, let's admit it, it is wishful thinking. So one thing we have to understand, or try to understand, is what are the factors that will increase the anti-diastolic pressure in our Fontaine ventricle. I mean, aging is a very likely good candidate, and we don't know whether there is an effect of ACE inhibitors or antifibrotic drugs on the increase in filling pressures. Fact is that chronic deprivation is a factor that will make the ventricle stiff, just like any muscle. If you don't use a muscle, it will stiffen up. And so if with the Fontaine state you deprive the ventricle from volume, depending on the degree of overgrowth of the ventricle, and that is because of the initial shunt, the bigger your ventricle was, the more you will deprive it as you go to the Fontaine state. The worse are your lungs, the lower the pulmonary flow will be, and again, the more deprived the ventricle will be. And also the fact that there is no stretch in a Fontaine ventricle, which a normal heart will have with daily exercise, will stiffen up the ventricle for sure. We're just writing up now an animal experiment where we did create a chronically deprived ventricle. And indeed, the data over there do confirm what we say over here. Chronic deprivation of a ventricle will make it stiff. There may be factors that will decrease the anti-diastolic pressure. And as I said, stretching the ventricle. I mean, there are some experimental conditions which you could do, but at the moment, they're clinically inapplicable. The best we can do is increase the preload. And that, for instance, with exercise, a right pump, right, or an RVAD, or make the flow through the whole system as good as possible. And as you see here, some collaterals or microregurgitation may have a small beneficial effect in these situations. Now, our formulas, the way we think about cardiac output and how it is determined, changes dramatically when we go from a biventricular circuit to a Fontaine. Here you see all the variables that we as cardiologists know: preload, heart rate, afterload, size, ejection fraction. Now, what do we know? What do we know in normals or in congestive heart failure? Well, in congestive heart failure, the left ventricular preload is unlimited. The heart rate is dependent on your function of the sinus node, your sympathetics, the catecholamines, and the Bainbridge reflex. The afterload usually is within limits. And in that situation, we know that stroke volume will be anti-diastolic size with ejection fraction, and taking all these independent variables into account, you can say that the cardiac output equals stroke volume heart rate, or this formula. That is what every cardiologist knows. This formula is always applicable also in a Fontaine circulation. However, in a biventricular circulation, these are the independent variables. And that is very important to realize that in a Fontaine circulation, it's completely different. For instance, the preload in Fontaine circulation by definition will be limited. That is the essence of the Fontaine circulation. The heart rate, very similar, but the Bainbridge reflex in such a heart will be attenuated. The venous return will be definitely attenuated. The afterload, we typically always say the afterload to the ventricle is augmented. However, we must realize that the ventricle will pump less against usually a lower pressure. So to be very honest, the afterload in a Fontaine ventricle will be decreased when you look at it at ventricular level. And the only really independent variable over here is the preload. And that means that your cardiac output actually is determined by your ventricular preload. All these formulas remain the same, but now they have become dependent variables. And the cardiac output now is determined by the pressure difference over your lungs divided by the resistance. In other words, your central venous pressure minus the ventricular pressure divided by the addition of your resistances. What happens in time? Well, pulmonary vascular resistance goes up a little bit, ventricular filling pressure goes up, CVD goes up, but the net resultant will be that the pressure difference will decrease, the resistance will go up, and this will result in a decrease in cardiac output. Now these over here are the two determinants that are important to us. We want our patients to have a low filling pressure and a high output. And as you say over here now, they are in competing conflict. So what do we impose on a Fontaine patient? By creating the Fontaine dam here with all its ingredients, we will create upstream congestion and downstream low flow. The low flow itself will increase the pulmonary vascular resistance. It will stiffen up the ventricle, which in turn will increase the congestion and the low flow, which will then cause a state of multi-organ failure, which in turn will enhance again the congestion and the low flow. Our handles that we have are over here, the pulmonary vascular resistance and the end diastolic pressure. Now comes the big thing. The primary effects of the damming are, as I said, the upstream congestion and the downstream decreased flow. The secondary changes are the congestion, the pulmonary vascular resistance that will further increase, the ventricle that will behave under abnormal boundary conditions, the systemic vascular resistance that will increase just like in anybody with a decreased output, collaterals and humeral. Is it the fact that this is secondary means actually that altering a secondary effect will rarely improve the primary problem. Yeah, you can, however, always deteriorate it. And so what do we see? As pulmonary vascular resistance increases and the suction decreases, this will make the primary effect even worse, and the primary effect then will make the secondary effect worse. The point I want to make is, for instance, if you drain ascites, yeah, you will not resolve the primary effect. You may attenuate it. If you increase the suction over here, you may attenuate it, but the primary effect remains the most important thing. So allow me to come back then to the most important thing in a Fontaine circulation, that is the pulmonary arteries, and how do we get to good, decent pulmonary arteries in a Fontaine circuit. Well, there is 4 phases that are very important in the growth and development of the pulmonary vasculature. In a normal person, it's only 2 phases. It's the fetal phase and then the postnatal phase, and normally a normal person will be at 100% of normal throughout his life. In a single ventricle patient going into the Fontaine tract, you see you have the fetal phase, and then typically early after birth, the patient will be shunted. The patient will outgrow his shunt. Then we will go to a glen, which will decrease by definition the flow to the lungs to almost half of what it would normally expect. The patient then will slowly outgrow his glen connection. Then we will impose on him the Fontaine circuit, where we will increase the blood flow, but always to levels lower than normal. and then we hope that this level will be maintained as long as possible. What we have to realize that this is the only phase that you will have catch-up growth of the pulmonary arteries, that you can get rid of the hypoplasia, but is also the phase where you can damage the pulmonary arteries and where you can get pulmonary vascular disease, or where you can get asymmetric growth. I'll jump over this. Now, what happens if you have a bad initial shunt? Like here, this neonate would get a bad shunt, and that means that his blood flow in the lungs is little. He will turn very soon blue, and in this patient, for instance, the team took the option to go for an early glen. I think that is usually a bad option. Why? Because then the blood flow will decrease. There is no further catch-up growth of the pulmonary arteries, and at the time of Fontaine, you get a mediocre result. We have, after the Fontaine state, we try to get this line over here as high as possible with medication or whatever. But we have to realize that this negative point over here is very difficult to alter. And as a matter of fact, this bad point over here was created by a shunt over there. And for me, as a pediatric cardiologist, being responsible for creating the circuit and moving the patient to get for an optimal Fontaine circulation, for me, far out the most important operation, the most important procedure in your patient is the initial palliation. If you get a good shunt and you get good pulmonary artery growth, creating the Fontaines, finalizing the Fontaine circuit is almost a home run. If your initial palliation is bad and you get distorted hypoplastic pulmonary arteries, whatever you do, you will end up with a poor Fontaine circulation. And then the second most important operation decision is the timing of the glen. Many centers nowadays will go to glen when the patient is either 4 months or 5 months or 6 months. I mean, it's almost the age that will determine whether they will go to the glen or not. What we have to realize is when you go to the glen, it means that the clinician has accepted to stop the catch-up growth of the pulmonary arteries. And if there is any asymmetry, the asymmetry will increase. And sometimes it may be wiser to consider a second wind or not go straight to the glen. Let me take you back to this cartoon over here. So when you see that the pulmonary vasculature is poorly growing, you could do something to the shunt, enhance the shunt or make it bigger, or even go for a second shunt. But nowadays, I mean, with ventricular protection is almost swearing in the church. But I mean, if you would do that, you would get up again, catch up growth of the pulmonary arteries, and indeed you would go later to the glen, but with nicer pulmonary arteries, so that by the time you get to the Fontaine, you get a better Fontaine stage. And getting this result over here is being determined by the decision you make at this point. That is something that pediatric cardiologists need to realize enormously. And that is sometimes not too difficult. For instance, these are the classical Gore-Tex shunts that we use in the neonates. Well, every Gore-Tex shunt can be stretched, and you can give a shunt a second wind. For instance, here, an infant that got a very, very small shunt at a small birth weight, and at the age of 4, where many people would go for a glen, for instance, we chose to dilate this shunt over here, have additional growth, so that by the time we went to a glen, we have nice, big, fat pulmonary arteries. Here another example that I borrowed from Yves Dudechem, who is now in Washington, D.C. He saw one of his patients over here after a glen with a nice right pulmonary artery, but with a smallish hypoplastic left pulmonary artery. Now, if you accept this, I guarantee you that by the time you go to the Fontaine, you will have a useless left lung, because the asymmetry will increase. If you believe that with a glen the asymmetry will decrease, then you believe anything. So what did Yves do in this patient? He did something that is written that you shouldn't do in textbooks, but I think he did the right thing. He divided the pulmonary arteries, put a big shunt on the left pulmonary arteries, and forced it to grow. And then a couple of months later, he was able to take down the shunt, reunite the pulmonary arteries again, and end up with a nicer Fontaine circuit that with at least a left lung that is worth talking about. So that is before the Fontaine. Once you have the Fontaine, how can you get more flow through the critical bottleneck? As I said, either you push harder, or you deal with the bottleneck itself, or you pull harder at the end. Now, pushing harder, there is something that the patient does himself with his muscle pump. The only way that a Fontaine patient can increase his cardiac output is by using his big muscles, squeeze the blood out of those muscles, squeeze it into the caval veins, and push it down the pulmonary arteries. That's the way he will increase his output. He has no other way. Another way we can do it is put in a mechanical pump or put an RVAT. I'll come back to that in a second. What about the bottleneck? Obviously, we want to have the bottleneck as good as possible, get the connection as good as possible, get rid of stenosis, don't have stenosis. We all now know that what oxygen or pulmonary vasodilators can do, but we all know also that even in the best studies, or the patients, the biggest responders usually will have no more than 10 or 15%, and on an average, the group of patients, Fontaine patients, will only improve about 4%. Respiration can be important, exercise can be important, so they have maximal recruitment. What about getting suction, pulling the blood into the ventricle? Well, if I would ask you, name me all the lucitropic drugs that you know that will enhance the suction, I think the list will be very, very short and you don't need any ink for it. Stretching the ventricle, I already discussed it slightly, is a problem. And for instance, an LVAD is a good solution for to replace a pressure pump if pressure is a problem. However, an LVAD is very poor solution for pulling in blood, and that explains why LVADs in Fontaines are usually of little use and more a disaster than help. Now, where should we look for better solutions, or what is the solution of evolution, or let me put it other ways, what is the solution of God? Well, if we look at the evolution of the animals, mammals nowadays all have right ventricles. So some animals have a system like a Fontaine circuit, but if you want to make this system very efficient, get a right ventricle in it. We cardiologists, we try to beat the solution of evolution or the solution of God. Let's admit that that will be very, very hard. So how to manage Fontaine failure? Well, first of all, the most important thing is actually the job of the pediatric cardiologist. He should get optimal building blocks, which means get lungs as good as possible. That is the highest importance. And the ventricle, as I mentioned before, of course he should be good. We have to respect the ventricle, but it doesn't need to be perfect. I mean, a ventricle with a slightly decreased ejection fraction, you will not see the difference because the output will predominantly be determined by your pulmonary vasculature. And here's then a conflict. In a small child, you need some flow to the lungs for them to grow, to get the catch-up growth, but significant flow may damage the ventricle, and that's where the pediatric cardiologists need to balance. Once the Fontaine failure is there, how can we treat it? As I said, deal with the critical bottleneck at every level you can find over there, or deal with the critical influencers. A high CVP is good for output, but bad for congestion. But I mean, you can solve both problems by putting it in a pump. And ventricular compliance, how to increase suction, is still a big problem. So far for these theoretical considerations. I thought it was also interesting to go quickly about some new lymphatic issues. You all know that protein-losing enteropathy and plastic bronchitis can be aggravated or elicited by Fontaine circulation. I'm not going to go over all these things that will make the problem, but fact is that there can be leak from the chyle into the gut or into the bronchi. Treatment strategies, the fact that there are so many means that there is not a single one that is really superior and can deal with all the problems. But I mean, you will recognize the thing: get rid of all the correctable lesions, convert, give steroids, give vasodilators, go for a secondary fenestration, resect the gut, but you cannot do that too often. Rashka showed how to reconnect the thoracic duct to the low pressure, and the people from Philadelphia are currently doing that more and more percutaneously. The point I want to make is over here with periportal lymphosclerosis, which was first reported a couple of years ago by the Philadelphia group. What they showed was that if you inject dye in the periportal dilated lymphatic vessels, you can see the runoff of these into the gut. And indeed, when they injected those lymph vessels with dye and were looking endoscopically into the gut, they could see the dye arrive over there in the gut. Now, instead of injecting dye, you can also inject glue, and by injecting glue, you can occlude completely these vessels. And that makes a hell of a difference, because like that, indeed, you can occlude those leaks. We ourselves have done quite a few now, and it is not the holy grail, but I mean, with 1 to 4 sessions, you can get a success rate over 70% in these patients. We still don't know how long it will last. It's possible that there will be a late recurrence, but I mean, I can tell you one thing: those 70% of the patients where it worked, that are the happiest patients you can find worldwide. The same thing for blastic bronchitis, where for one reason or the other, and there are many why the thoracic duct will not function that well in a Fontan patient. If there is obstruction over here, the lymph will be blown into the upper mediastinum, but also into the lungs. And again, there is a bunch of techniques that you can do. The people from Philadelphia promoted putting either a stent, covered stent in order to seal off those leaks or glue embolize them. I will allow myself to give a short message on a patient we recently treated here, thoracic duct, where you see that the lymph is being blown in the upper mediastinum, but leaking also into the lungs. Now, in this patient, we showed that the lymphatic system indeed was sick, with big lymphatics next to the bronchi. And then, just as you can do with the liver, inject a peribronchial. I mean, with an EBUS guided lymphoscope, you can inject with the needle into those lymph nodes, and by doing that, you can occlude them and also glue all the lymphatic vessels that you don't want to see. Here in this patient, we did puncture all those lymphatics, and I mean, right now with 14 months of follow-up on such a patient, we were able to deal with that problem. And again, this makes a hell of a difference in patients like that. Now, this is my last slide. What was I taught? Well, I was taught that Fontaine operation was cardiac surgery. Well, nowadays I teach it is non-cardiac surgery. And allow me to say it even bluntly, early on, the Fontaine operation has almost nothing to do with the ventricle. Everything you see at ventricular level are secondary changes. Indeed, the ventricle is still big. It is actually overgrown. That's a word that is not commonly used, but I mean, has a very specific meaning. The afterload, there's a difference between an increased afterload and, in most Fontaine patients, increased vascular resistance and a decreased afterload. It is clearly different. We no longer speak about heart failure. It's much wiser to speak about circulation failure, because that keeps your mind open, and that tells you that you should go and look for the critical bottleneck, and usually you will find it in the new portal system, either the connection, the pulmonary vascular resistance, or the increasing filling pressures. This formula obviously still is true, but we have experienced that heart rate, for instance, is not an influencer of output, and the ventricle does not determine its stroke volume, it undergoes its stroke volume. And this formula is much more correct, where it says that the cardiac output in a Fontan patient is actually equals the transpulmonary flow with all these variables. And that means if you do a maneuver, if you give a drug, and you do not change any of these variables, I mean, your drug will do nothing to a Fontan circulation. Or vice versa, if you want to investigate the efficiency of a drug or a maneuver in a Fontan circulation, these are the variables you have to measure. Otherwise, you will end up measuring secondary changes and not the primary changes, what is important. As pediatric cardiologists, we should work heavily on avoiding failure, because treatment of failure is very, very, very difficult. And the other lessons are: go for the critical bottleneck and be aware there's only one. Know the difference between primary and secondary effects. Don't use dependent variables in your formula like here, but use independent variables, because otherwise you will end up looking at secondary changes which are irrelevant. And always be critical and do not believe your wishes, as we have done for years early on in the patients with Fontan circulation. I thank you for your attention.
Thank you very much for this amazing presentation. And it's already 9 o'clock, but I think such a great talk deserves 10 minutes of discussion. So happy to go on. There are several questions on the chat, so I'm going to start. So the first question says, great presentation, many thanks for the invitation. Do you think that rather avoiding the deprivated ventricle, some patients due to reduced pulmonary blood flow, more collaterals are generated, creating a left-to-left shunt overloading the single ventricle and make it fail and increase the LVDP? So quite complex.
It is complex. First of all, we have here the habit to also, as our patients go from pediatrics to adults, to do a cath on them and see what's going on. And I can tell you one thing: a good Fontan does very little collaterals, and the bad Fontans always invariably will have collaterals, and they will be increasing that throughout their life. I have seen, when I occluded collaterals, big collaterals, indeed that the efficiency of the Fontan circulation in the short term does improve. In the long term, indeed, it may be a factor that may influence the increasing anti-diastolic pressure. But typically, the patients that are in bad shape, your first concern will be try to improve them as good as possible on the short term, and problems later on. I mean, most of us will be very happy to deal with the problems of our Fontan patients in 10 years from now, if they survive those 10 years first initially. And so big collaterals, yes, I would occlude them. Small collaterals, I wouldn't bother.
So Dr. Bellman, thank you for the informative presentation. May I ask you your insights regarding late Fontan takedown for failing Fontans and Fontans with 2 ventricles? What wisdoms do you have to share with us?
Sorry, say it again.
What is your insights regarding late Fontan takedown for failing Fontans and regarding Fontans with 2 ventricles?
Okay. Late Fontan takedown, I think, is overall it is almost a disaster. It's like giving a secondary fenestration late in a Fontan patient. Usually you will make those patients very unhappy because you will have to make big fenestrations and make them very blue in order to improve the congestion and in order to get some increase in output. It may be a step to on the way to transplantation, and in my center we would prefer to go for transplantation instead of going for Fontaine takedown. Fontaine takedown will be considered if we think that the patient might die or get further damaged while waiting on the transplantation list. Now, the second question, if you have a failing Fontaine with 2 ventricles, of course, you always have to ask yourself, did this patient really need a Fontaine operation, or could you have gone to a biventricular repair? Now, in our center, we have little experience with that situation because we always have tried to use 2 ventricles if possible, and in the cases where we decided to go for a Fontaine, usually we don't change our mind because keeping a biventricular circulation in a patient where there are major problems, either the inflow, the septum, or the outflow, it's hard to deal with. But on occasions, we have had here also a Fontaine patient that came in and where the Fontaine circuit was failing, and where we decided to take him down and go to a biventricular circulation with success. On the other hand, going for 1.5 ventricle is also not a bad option. I mean, if you have a patient with preferred flow, so the blue blood going preferably to the pulmonary arteries, I don't mind to leave a patient with 1.5 ventricle, which means a dilatable band, a Glen, and take it from there. In the long run, those patients will be indeed a little bit limited by cyanosis during exercise, but they will avoid the problems of chronic congestion, which all of you know are big problems 20-30 years down the line in the Fontaine patients.
That was the question I had ready for the last question. So you answered my question about leaving patients with 1.5 ventricle. So there's another question here. Says what is your rush or what that explain that age is a factor for deterioration in patients with Fontaine?
2 big determinants. First of all, the longer you look at a patient with a Fontaine circuit, you see his end diastolic pressure go up. Yeah, my very best patients in the long run, or the one that are poorly symptomatic, keep good ventricles with low filling pressures, but almost invariably the failing ones will have increasing filling pressures. And so if we could halt that process or reverse that process, that would be very interesting and very important. And so it's now our feeling that the chronic deprivation is a main reason for that. I mean, I'm sure that it is a factor. I don't know if it's the only factor or the most important factor, but it looks like that. And then the second thing is that with time, pulmonary vascular resistance may increase. I mean, not obligatory, but I always quote on the paper from Mitchell, who assessed very carefully his Fontaine patients before transplantation, and he could observe that the ones that deteriorated and that required a transplantation, that they had a moderate increase in their pulmonary vascular resistance. And I think these 2 factors will make that most Fontaine patients in time will deteriorate in such a way that the circuit is no longer viable. So, but I think that the increasing filling pressure probably will outbeat the increasing pulmonary vascular resistance. But there are two things to work on.
So we have time for a couple of questions. So there's another question here from Dr. Yamamura from Japan. So several papers advocate that there are hemodynamically different types of failing Fontan. For instance, you can have a high cardiac index, high CVP Fontan, failing Fontan, or a low cardiac index, low CVP failing Fontan. What do you think is the reason for these differences, and how would you treat them?
I always would try to find the critical bottleneck, why a patient, why the circuit is failing, yeah. And so if the reason would be increased pulmonary vascular resistance, then pulmonary vasodilators may be very helpful. Training and exercise will be helpful. And I think in the short time, that will be your two most important factors. If, however, increasing diastolic pressures in the ventricle, and so we all have seen undoubtedly patients with filling pressures, A waves 20, 25, even 30. That is a big problem, because this stiffening ventricle, to loosen it up with the Fontaine state, right now we're not good enough, and we have almost no options. In the high output state, there you would have to look, see where you have reserve. If that is because of big collaterals, I certainly would occlude them. And I presume, of course, that with your maintenance monitoring of Fontaine patients, by definition, you must have excluded all obstructions and things like that. And also obstructions that are maybe at initial sight not obvious. We have learned now that, or we see that when the surgeon in a child, when he was creating the Fontaine circuit, my surgeon, for instance, frequently had used a 16mm Gore-Tex conduit. Well, for an adult, a 16mm Gore-Tex conduit is too small, full stop. Yeah, you see that your inferior cable vein caudal of that conduit will dilate enormously, clearly demonstrating that the body wants something bigger. And in many patients so far, we have stretched and stent dilated those conduits to bigger sizes, and many have improved on that, on just that maneuver. It is still hard to say in advance who is going to improve and where it's not going to improve, but so optimization of your Fontaine circuit as the patient is outgrown, and making sure that everything is perfect. The conduit is big enough. There is no tenting. There is no stenosis at the pulmonary arteries. A big lesson is, don't wait for problems to occur, because it is very difficult to get rid of the problems. You must tackle the problem before it presents itself. And when you take over a Fontaine patient, you must be very sure that everything is as optimal as possible. I also stress my patients that they have to exercise every day. I tell them that they should sweat every day, at least for 15 to 30 minutes, just to flush their system, get their pulmonary vasculature happy. And if that exercise would be able to stretch their ventricle, attenuate or slow down the increasing filling pressures of the ventricle as long as possible. And that would be my biggest tricks to keep them as good as possible. So, but prevention is the big thing.
So I think we have time for one last question, and this question is: if someone with a RA2P Fontan has a liver cirrhosis, would you recommend to go for a Fontan revision?
To go for a Fontan?
for a Fontan conversion, for doing a TCPC?
Yeah, I still am a profound believer of Fontan conversion, and so I think we converted most of our Fontan patients as it became obvious that the atrial pulmonary connection in the long run is going to be a bad thing. That means that most of our Fontan patients with an atrial pulmonary connection have been converted before they came up with big problems. I think it's much more difficult in a failing Fontan with, for instance, protein losing enteropathy, wasting, significant muscle wasting and things like that. Then the conversion becomes high risk. But I've seen very nice results of streamlining the circuit and get rid of a huge dilated blood swirling right atrium and convert them to a TCPC. So overall, I would say, yes, I'm in favor of conversion, but if you do it too late is too late. I wouldn't wait until you have the knife on your throat or when the chest is completely filled with a big, huge dilated right atrium.
I agree. So I think we have a million questions. We could be here for the rest of the day, but unfortunately we have to close the session. I have to say thank you again for an amazing talk, very thoughtful and amazing Fontan physiology, and thank you for joining us today. And to all of you that have joined us, thank you very much for joining the session this morning, and good morning, good afternoon, or good evening, wherever you are in the world. Thank you, Professor Gewillig, and see you. Thank you very much. Thank you.
Most welcome.